And here we go with the electrical conduction of the heart. So shocking. This is how we get the electrical signals through the heart in order to keep the heart beating in the correct pattern. If we have too much of an irregular beat in the heart, we can't get blood in and out of the heart in an appropriate manner. We've got to be able to open up the chambers at the proper time, allow blood to fill both atria, close the valves between the atria and the ventricles until we're ready, push it down into the ventricles, and then out of the ventricles into the lungs to the body. If we cannot do that in the proper manner, we can actually get blood, which will start to circulate in the same chamber of the heart. If we circulate blood in the same chamber of the heart, we can actually throw a clot. We don't want that. So this electrical conducting system of the heart keeps things moving in a rhythmic, in a correct manner. So there are cells that are in the heart that are hyperexcitable and also pacemaker cells. We're going to go through all of those different cells and what they do. They are excitable. They conduct electrical activity from one cell to the next, and it happens automatically. Okay, so we have cells that have those three capabilities. Now, do we not have nerve supply to the heart? Absolutely. But there are some cells that can automatically beat on their own without the control of nerves going to it. When we look at a picture, and I have all the functions of these different parts written down for you, so let's just get the anatomy down first. The signal will begin in the sinoatrial node, which is also known as the pacemaker. That is in the upper right, anatomical right, not our right, anatomical right of the heart in the right atrium. This will send signals across to the left atrium as well as down to the junction between the atria and the ventricle. At that point, those are called, or it is called, the atrioventricular node. Now, once again, where the SA node is, where the AV node is, where the intraatrial bundle is, the Purkinje fibers, these are all, and the bundle branches, these are all hyperexcitable cells. These cells are a little different in these areas than the rest of the cells in the heart. So I'm just sort of drawing them in. You can see where they all are. They're a little hyperexcitable, and they tend to fire when stimulated a little bit quicker than the rest of the heart. So they're going to carry that signal through the whole heart. They also, in and of themselves, in certain areas, have their own contractile beat or pacemaker. Okay, so the SA node, and we're going to look at all those rates and rhythms in just a little bit, establishes the normal 60 to 100 beats per minute. That is the rhythm at which these cells will send the electrical signal. If we were to go to a different area and say choose this area, these cells are going to fire at a different rate and rhythm. So it's important that the SA node begin the electrical signal because it keeps that regular 60 to 100 beats per minute, because that is what it is set at. That is why it is the pacemaker of this electrical circuit. If it is not working and we set the pace by another electrical hyperexcitable group of cells in the heart, it will be an abnormal rate and rhythm. And like I said, I have all those numbers printed out for you in the next couple of slides. In a normal heart, we'll begin the electrical activity in the SA node. Once again, it'll send signals to the atria on both sides, down to the AV node. That continues down to the left and right bundle branches. Those bundle branches then come up as Purkinje fibers. And they all have different names, but they're all hyperexcitable cells that live in the heart that contribute to this electrical circuit to keep the regular rate and rhythm of the heart going at the right pace. Now, there's one thing you probably remember that this book doesn't have. Right here is the bundle of His. Okay, and the bundle of His which is located right in that pattern, or right in that location that I just drew, is just the step between the AV node and the right and left bundle branches. And it was named after Dr. His, H-I-S. So bundle of His, you might want to add in there. So the good thing to know about this as well is you can see that electrical circuit begins at the top at the atria, stimulates them to contract, pushes blood down from the atria to the ventricles, and then it comes down and around the ventricles and it squeezes them to push blood up and out, continuing with that really rhythmic movement of blood through the heart and not letting it settle in one place. And the electrical circuit kind of pushes it along in that direction as well. Now, getting down to the nitty-gritty definitions, those impulses originate in the SA node, which has a regular rate and rhythm of 60 to 100 beats per minute. The impulses then travel through the right and left atria, causing those atria to contract. They go down, that signal goes down to the atrioventricular node in the right atrium. That's right between the juncture of the right atrium and the right ventricle. It's adjacent actually to the septum between the ventricles. And it sends the signal down from the atria and starts to send it down through the ventricles. Now, if the SA node is not active, if it is damaged, suppose we've had some sort of infarct or tissue death in the SA node, and the AV node picks up the electrical signal in this electrical current, or circuit, I should say, the AV node will only contract or beat at 40 to 60 beats per minute. 40 to 60 beats per minute is not a good rate and rhythm for our heart. It doesn't allow the heart to get enough blood in and out of it to maintain our tissues and provide that perfusion that we need to keep our tissues healthy. Impulses are delayed in the AV node to allow for complete ventricular filling, and then impulses move down through that bundle of His and then into the right and left bundle branches. It then swoops around the bottom of the ventricles, as I showed you in the picture, as the Purkinje fibers. Those are the electrical circuit systems and pathways that cause the ventricles to contract. The ventricles can initiate impulses if the SA and AV nodes fail. It will only initiate impulses at 20 to 40 beats per minute, which is inadequate for our heart to provide perfusion out to the tissues. The AV node can provide enough to allow us to continue to survive, but we won't be at functioning or optimal functioning. Electrical activity also is considered when we talk about how the atria and the ventricles contract. And the way that we see this or graph it is on an EKG. And the EKG helps us to see when the heart is active and when it's resetting. When the heart is active, it is called depolarization. So we have atrial depolarization, which means that is when the atria contract. We have ventricular depolarization, which means that is when the ventricles contract. Now, repolarization is when the atria and ventricles recover. Repolarization means recovery. This is when we reset ions, and we have to have the proper balance of ions in and out of cells in order for them to function properly, and that's when these ions reset themselves. So ventricular repolarization would be when the ventricles are resetting their proper ion balance. Atrial repolarization is when the atria are resetting their proper ion balance. So as I said, this is read in an electrocardiogram, an ECG or an EKG, and we have three main waves and complexes. So This is probably familiar for you guys, and we're going to follow, I think, the main lead, which is your basic P wave, QRS complex, and T wave. In a normal heart, that P wave is atrial depolarization. This is when the atria contract. QRS complex is when the ventricular depolarization is occurring, or when the ventricles contract. But hidden inside of this is atrial repolarization. I'll explain that when we get to the chart. I think it's a little bit easier to understand. T wave is ventricular repolarization or resetting of the ventricles. So let's actually pop over to the chart and we'll back up in the notes in just a second. So here's a normal EKG or ECG. The P wave is simply when the atria contract, right here. And the reason we get this electrical reading is because in order for an atria or a ventricle to contract, ions need to move. So what an ECG is doing is reading the movement of ions. So this P wave is a little bump up, showing that a little bit of ions have moved when the atria have contracted or depolarized. Now, think about this for just a second. How much bigger and thicker are the ventricles? This QRS complex is going to be much bigger, and this denotes when the ventricles are contracting or depolarizing. Now, interestingly enough, well, let's finish this out and then I'll explain it. After the ventricles contract, we get to this T wave, and this is when the ventricles are resetting or repolarizing themselves and putting the ions at the proper concentrations in and out of cells. So that's a basic gist of this. Now I ask you, question time, going off-roading question time. Where is the atrial repolarization? Any guesses? Think about it for just a second. It's going to be hidden in this QRS complex. It's much smaller. It happens at the same time. So it's frankly just covered up by ventricular depolarization. Okay. As always, if there's questions about any of that electrical activity, let me know. I know it's slightly confusing. Okay, so back to this slide. I just backed up one slide. You can see the ECG. I went over the P wave, atrial depolarization. QRS complex is ventricular depolarization as well as atrial repolarization, if you'd like to write that in there. The T wave is ventricular repolarization, or when those ventricles are resetting themselves. Excuse me. Now, sinus rhythm is electrical activity when the impulses originate in the SA node. We call the sinus rhythm a quote-unquote normal rhythm, normal rate and rhythm for that heart. Dysrhythmias are going to be abnormal electrical activity, mostly seen from myocardial infarctions. We could get it from electrolyte imbalances as well. Sodium, potassium, and calcium are the three main electrolytes that are really important for the heart to function properly. So if there's an imbalance with those, we can have a dysrhythmia with the heart. And I mean a severe imbalance. Here's the ECG once again. Conduction control is done by those electrolyte signals. I could put the cart in front of the horse. Sodium, potassium, and calcium. That's a whole lecture unto itself about how those balance themselves. So just realize that the three important electrolytes for heart contraction are sodium, potassium, and calcium. This is why it's important to have a good balance of our electrolytes in our system. Now, we also regulate our heart rate and rhythm by the autonomic nervous system. Primarily, that'll come from the medulla. We'll talk about nervous system in the future, but if you don't remember where the medulla is, it's in the brainstem. So you could get a little picture and look that up. Now, the endocrine system also contributes to the conduction control or the rate and rhythm. If we have a spike in epinephrine, we will have a spike in the heart rate. If we're getting ready to exercise or we get stressed or we get embarrassed, we'll release epinephrine, which will increase the heart rate. Chemoreceptors keep a balance of concentrations of substances in the blood, and baroreceptors sense the pressure of blood in that cardiovascular circuit that I told you about. That's a closed circuit. Baroreceptors make sure that we have enough pressure to get blood up to the brain. Chemoreceptors will keep track of the chemicals in there to make sure that we have enough oxygenation. There's many things that those sense, but in dealing with cardiovascular, chemoreceptors will sense actually CO2 first. That's going to be the main driver of respiration, and also levels of oxygen. So conduction of rate and rhythm of heart rate and blood pressure really is this fine balance between many systems, and it amazes me that it keeps doing it all by itself. It is question time. Now, the QRS complex on an ECG shows ventricular depolarization, atrial depolarization, atrial repolarization, ventricular repolarization, 2 of the above. What do you think? Go ahead and pick your answer. And guess what we're going to move on to? We're going to move on to a little blood pressure. Under pressure. If you're a fan of old rock, you know what I'm talking about. Now, blood pressure is going to be the pressure that blood exerts on the walls of blood vessels, and we measure this to see how hard the heart is working, and we measure it by showing systolic and diastolic numbers. Bread and butter stuff, I know you know that. Now, systolic will be the top number. That number shows the pressure on blood vessels when the heart is contracting. Diastolic, I always remembered as dying off, is when the heart is dying off or relaxing, and that is the bottom number. Now, blood pressure should be about 120/80 as we check it with our sphygmomanometers or blood pressure cuffs. Pulse pressure is the difference between systolic and diastolic. The higher the pulse pressure, the higher the pressure on the heart. If it's higher, it means the heart is pushing blood out harder, but we can also see that with that systolic number as well. So I do know that some people use that pulse pressure to show if there's even more excess stress on the cardiovascular system and the heart itself. So, influences on blood pressure. What will influence our blood pressure is cardiac output. Don't let this blow your mind. It's simply stroke volume, which means how much blood is pumped out of the heart per pump, and the heart rate. So it'll give you the heart rate in beats per minute times the volume of blood coming out per pump will give you the cardiac output. That's all it is. It's just showing how much the heart is working to get blood out of it. It gives you, obviously the rate and the volume of what your heart is pumping out. Peripheral vascular resistance. This is, okay, so if you think for a minute, your left ventricle has to pump blood out of it into the aorta to get out to the body. Okay, are you with me? If you can picture that, please picture it. If you can't picture it, go back to the heart and review it. So that left ventricle is going to pump blood out against the aorta. That aorta leads to the large blood vessels of the body. Those large blood vessels will get smaller and go to the arteries, and smaller and go to capillaries. If you have a lot of hard blood vessels, it is harder for that left ventricle to pump blood out into the aorta because there's just more resistance. If you think of a garden hose, if I were to take us all outside and we're playing with a garden hose and you want to spray somebody far away, you put your thumb over the opening of the garden hose, which decreases the diameter of that garden hose, so you can force the pressure of the water out faster. It's the same concept in blood vessels. If you decrease the diameter by hardening arteries, and that's what happens when arteries get hardened. We get inflammation on the inside of these arteries if we're looking at one on ends. This is what I'm showing you as an example. So we get some inflammation here, and that inflammation will actually draw cholesterol, and that cholesterol will make the walls harder, but it also makes them thicker, and it makes this opening smaller. And because that opening is smaller, you're decreasing the diameter, just like you decrease the diameter of the garden hose, we're going to increase the pressure in those blood vessels. So when you try to pump blood from the left ventricle through a smaller, narrower, harder, inelastic blood vessel, you're going to have an increase in your blood pressure. You're going to have an increased stress on your left ventricle. Does that make sense? If it doesn't, of course, let me know. Now, the sympathetic nervous system can increase peripheral vascular resistance because if it is triggered, it will cause an overall slight contraction of blood vessels, which increases your systemic cardiovascular pressure or blood pressure. Does that make sense? So your sympathetic nervous system will kick in when you're stressed out, when you're exercising, when you're nervous. It'll release epinephrine, and the response to that release in epinephrine, or that stress hormone, is to slightly contract all your blood vessels. And if you slightly contract all your blood vessels, you'll increase the entire pressure in the cardiovascular circuit. And that'll increase your peripheral vascular resistance as well. Parasympathetic nervous system calms us down, and it will slow the heart rate, which will allow blood vessels just to relax. Parasympathetic nervous system, interestingly enough, does not send nerves to the blood vessels, but if it's stimulated, it counteracts the sympathetic nervous system and allows blood vessels just to relax. So all of these things can influence our blood pressure and cause more stress on the body as it is sending blood out of the heart. Afterload and preload. Okay, I don't know if you remember this or not. Afterload is the pressure needed to eject the blood. Now, if you have thick blood vessels due to atherosclerosis or hardened blood vessels, you can have an increased afterload because, and also blood viscosity, if you have thick blood. Your heart is simply going to have to work harder to push blood out. Preload is the amount of blood that returns to the heart. You need the proper amount of blood coming back to the heart so we can reoxygenate it and send it back out. We also need to fill those ventricles and get all the blood out so we can get enough blood back in to reoxygenate it. Backing up to afterload. If the afterload is too hard, if the heart cannot push all the blood out, some will be left behind. That's also a bad thing because we could start to develop clots. That's when we really have a really huge stressful situation, bad atherosclerosis in the blood vessels, really making the heart work hard to push the blood out. The other thing that happens when the heart works really hard is you can actually stretch it out and get a flabby heart that doesn't work really well. Another thing that can influence blood pressure is hormones. We have antidiuretic hormone and renin-angiotensin systems. These are kind of complicated things, so I'm actually going to pause the tape and I'll start those in the next one. I do want you guys to answer a quick question for me. Afterload is due to increase in pressure in the arterial system. True or false? Sorry. Our afterload is due to an increase in pressure in the arterial system. True or false? What do you think? We just went over it. All right. If you have any questions, we're getting into more heavy duty stuff, please shoot me an email. I'd be happy to get back to you. I'll see you in the next video.